All right. Is everybody able to see the slides?
Yes, we can.
Okay, perfect. Okay, so today I'm going to be talking about thyroid diseases. Mainly this talk is going to look into hypo and hyperthyroidism and basically how to interpret thyroid labs. And then we'll briefly talk on thyroid emergencies. So just to kind of give a brief overview of neck anatomy, here's the thyroid gland. It sits in front of the trachea. The recurrent laryngeal nerve kind of courses behind the thyroid gland and it innervates the larynx. And so when you have any sort of thyroid surgery or for like thyroid cancer or thyroidectomy, sometimes that recurrent laryngeal nerve can get damaged, and that's what causes some of the kind of post-op symptoms that patients have and that we have to worry about. Also, if patients have a goiter or an enlarged thyroid, you can have compressive symptoms, especially some, shortness of breath, and that's also related to kind of its location in the trachea. So I just wanted near the trachea. So I just wanted to point that out. This is just what a thyroid looks like on an axial view of an ultrasound. So you have your right lobe of the thyroid gland, the isthmus that connects the two lobes, and then the left lobe sitting right in front of the trachea. So moving on to thyroid function tests. So the thyroid is controlled by the hypothalamic pituitary axis. So our hypothalamus releases TRH, which tells the pituitary gland to release TSH. So your TSH is your signal from your pituitary gland that then tells your thyroid gland to make both T4 and T3. Most of the production from the thyroid is T4, and then your body converts it to T3, which is the active hormone. These are the different studies that you may order in an outpatient setting to evaluate for thyroid hypo or hyperthyroidism. Thyroid hormone is bound to TBG or thyroid binding globulin. So total T3 and total T4 is the bound form, and then free T4 and free T3 are the unbound form, and those are the active hormones. This is a chart from UpToDate that basically goes through different patterns of the thyroid labs and how you can interpret them. And so I think it's a helpful chart to look at when you first are getting a bunch of thyroid labs to see if they fall in the hyperthyroid category, or sometimes we see kind of funny lab patterns that may not quite fit the hypo or hyper that we typically think of. And so this is kind of a starting place that you can find on UpToDate. So there are a couple different things that can affect thyroid labs, and that's what you want to keep in mind when you're measuring thyroid function. So biotin is one of them. So patients sometimes take higher doses of biotin for hair and nails kind of as an additional supplement, and that can affect your thyroid labs. So you always need to keep that in mind when you're interpreting thyroid labs. And biotin can basically make you look hyperthyroid, so it can cause your TSH to look low and your T4 and T3 to look elevated, even though they're not necessarily hyperthyroid. So if you get funny labs and a patient is on biotin, it's basically it's best to just hold the biotin for about 3 to 5 days and then repeat your thyroid labs. Pregnancy can also affect the measurement of thyroid labs. So in pregnancy, your estrogen goes up, which increases your thyroid binding globulin. And so your total T4 and T3 are going to be elevated in pregnancy. And then in non-thyroidal illness, your labs are affected, and we'll look at that pattern right now. Basically, in non-thyroidal illness, so if you're sick for any other reason and it has nothing to do with the thyroid, you can still get abnormal looking thyroid labs. Basically, everything is decreased. So your TSH, your T3, and your T4 may all look low in non-thyroidal illness. And this is thought to be an adaptive response by your body to mitigate catabolism associated with severe physiologic stress. So you don't have to treat non-thyroidal illness. You just have to be able to recognize the lab pattern and that it and the reason of why it might be all showing low. And when slowly those labs will start to recover as the patient gets better. And this is just showing that basically during severe illness, during the severe illness part is when the levels are going to kind of start to decrease. So your total T4, your total T3 are going to start to decrease. And then during recovery, those levels are going to start to come up. Same with your TSH. Early on, it will be low, and then slowly it will kind of go back into the normal range. And it will actually, in the recovery phase, maybe even slightly higher in the normal range. So moving on to hypothyroidism. So if a patient is hypothyroid, they might come in with a variety of symptoms. On exam, the thyroid can either be enlarged, normal, small, or absent. So really the exam, can't tell you if they're hyper or hypothyroid, but it's still good to, of course, do a thyroid exam. Some symptoms that they might have are fatigue, cold intolerance, weight gain, bradycardia, constipation, swelling and puffy skin, and menstrual irregularities. So if a patient comes in kind of reporting these symptoms and you want to work them up for hypothyroidism, you'll check their TSH and their free T4. Your TSH and hypothyroidism will be elevated while your free T4 is going to be low. These are the various causes of hypothyroidism. So you can have congenital hypothyroidism, Hashimoto's thyroiditis, which is the most common form. This is an autoimmune disease with antibodies against the thyroid. And we diagnose Hashimoto's thyroiditis with thyroid peroxidase antibodies. So TPO will be elevated in Hashimoto's, and thyroglobulin antibodies will be elevated as well. Those are not specific, but they will be elevated in Hashimoto's. These are some other causes of hypothyroidism. So you can have destructive thyroiditis, post-radioactive iodine thyroiditis, or hypothyroidism, which is the goal when we give radioactive iodine for hyperthyroidism. You can have post-surgical hypothyroidism, so patients have thyroid cancer, they've had their thyroid removed, and then some medications can be associated with hypothyroidism. Lithium use, amiodarone use, which is common in our patients, and then some of the newer medications used for cancers like nivolumab. So those can also cause a lot of endocrine issues. And we do see hypothyroidism in those class of medications as well. Treatment for hypothyroidism is relatively straightforward. So basically you're just replacing the thyroid hormone with levothyroxine. So levothyroxine is T4. A weight-based dose of levothyroxine is 1.6 micrograms per kilogram. So this can get you an idea of kind of where to start the patient on. The main thing you want to tell your patients is that they should take their thyroid medication first thing in the morning on an empty stomach. They should wait about 30 to 60 minutes before eating. And they need to separate it from any calcium or iron supplements by at least 4 hours. So it is affected by, food and some other medications. So it's important that they do take it first thing in the morning on an empty stomach. Once you start a patient on levothyroxine, you're going to want to retest their thyroid labs or TSH in about 6 to 8 weeks after any dose change or after starting the medication. So it does take up to 6 to 8 weeks before you see a change in the TSH. Sometimes you may not always want to start on a full replacement dose. So these are kind of special populations that you want to think about. In pregnancy, they have increased requirements of T4. So usually as soon as the patient finds out they're pregnant, we preemptively increase their dose by about 2 pills, which is about 30%, due to the increased need of thyroid hormone in early pregnancy. And then in adults with coronary artery disease, you might want to start at a lower dose because it can cause arrhythmias and increase angina. So, and as well as in older adults, you want to be careful as well for kind of those similar reasons and the impact on the heart. So sometimes you might think about starting at lower doses, like around 25 micrograms or 50 micrograms and titrating up from there. So subclinical hypothyroidism. This is when your TSH is elevated, but your free T4 is in the normal range. So basically, in subclinical hypothyroidism, you have an elevation of TSH, usually anywhere from 4 to 10, with a normal range free T4. Once your TSH starts getting above 10, you do want to treat them. So there's not really any randomized control trials showing benefit of treating subclinical hypothyroidism. However, in certain populations, we do we do think about treating them more aggressively. So in patients who are pregnant, especially if they have positive TPO antibodies, but they're in that subclinical hypothyroid range, we think about treating them because in the first trimester, basically the baby is dependent on the mom's thyroid levels. They haven't developed their own thyroid yet. And so it is important to treat them initially. And then in patients who have infertility or having trouble conceiving, that's another area where we do definitely treat subclinical hypothyroidism. So moving on to hyperthyroidism. So some of the symptoms that you might see with hyperthyroidism are, the opposite of the low thyroid. So weight loss, palpitations, tachycardia. They may have complained of more frequent bowel movements, muscle weakness, fatigue. And again, you can have menstrual irregularities and miscarriages. These are the different causes of hyperthyroidism. So Graves' disease is an autoimmune disease, basically with stimulatory antibodies against the TSH receptor. It can also be associated with Graves' eye disease or thyroid eye disease. You could have a hyperfunctioning or hot nodule, which is another cause of hyperthyroidism. You may have thyroiditis, so this can be for a variety of reasons. You could have painless thyroiditis, and sometimes this is associated with like an upper respiratory or viral infection. You can have postpartum thyroiditis, so sometimes within the first year of pregnancy, patients or after they deliver, they'll come in with abnormal thyroid labs, and it might be just related to postpartum thyroiditis. Amiodarone can cause a thyroiditis. Like I was mentioning, those immune checkpoint drugs are also kind of common causes of thyroiditis that we see now. You can have subacute thyroiditis, in which a patient will have more pain on exam and they may complain of tenderness of the thyroid. Early pregnancy has some thyroid changes or has some TFT changes as well that makes the patient look hyperthyroid. And then congenital hyperthyroidism is another cause of hyperthyroidism. In terms of diagnosis, you'll see a low TSH, an elevated free T4, and an elevated total T3 when you diagnose hyperthyroidism. In terms of evaluating hyperthyroidism, generally once a patient comes in with elevated thyroid labs, what I typically do is first evaluate for Graves' disease. So you can do that with just a blood test. So you can send off a thyroid stimulating immunoglobulin and a thyrotropin receptor antibodies. If those come back positive, you don't necessarily need to get an uptake and scan because you already have your answer. If those come back negative, then you want to go on and do an uptake and scan. So an uptake and scan will basically show you, does the patient have kind of diffuse uptake, which is more consistent with Graves' disease? Do they have focal uptake, which is more consistent with a hot nodule? Or do they have decreased uptake, which is more consistent with thyroiditis? And so if you don't get your answer from the blood test, then the next step would be to get an uptake and scan. A thyroid ultrasound with vascularity never gives you the reason why they have hyperthyroidism, but kind of supports it. So if you're getting an uptake and scan, you'll also want to get an ultrasound along with that, basically to look for any underlying thyroid nodules. So this is just kind of pictures of an uptake and scan. You can see in thyroiditis, there's really no uptake. In a hot nodule, it's kind of focal uptake. In Graves' disease, you kind of see bilateral uptake across the whole gland. You can have a mix of hot and cold nodules in a patient who has multinodular goiter. And so those are the different sort of pictures that you might see in an uptake and scan. So treatment depends on the cause of the hyperthyroidism. It's due to an overproduction problem, which is both in Graves' disease or hot nodules. You have several options. One is to use medications like thiamides, like methimazole or PTU. So some side effects of these medications to think about: patients can have rash. You want to warn them about agranulocytosis. So if they're taking these medications and they get any sort of fever or sore throat, they need to let you know right away so that you can stop the medication and check their CBC and make sure their counts are okay. Radioactive iodine is another option for treatment for both Graves and hot nodules, surgery, or beta blockers for symptomatic control. So in both Graves and hot nodules, you can really use you can really think about medications or the radioactive iodine for both of those. If you do give radioactive iodine in Graves' disease, it will kill off the entire thyroid. So the radioactive iodine will be taken up by the entire thyroid, and they will become hypothyroid. So you will have to replace their thyroid hormone. In hot nodules, the goal is to really just kill off the area of the overproductive nodule. And so the goal is to try and make them euthyroid. That doesn't always happen. They still are at risk for becoming hypothyroid, even with radioactive iodine in a hot nodule. In Graves' disease, some patients go into remission after about 18 months of treatment on medication. So it's always reasonable to start with medication to see if they go into remission and if their thyroid labs normalize after that, and you might be able to get them off with the medication. And then they do have a risk of going back into Graves' disease. So you have to continue to watch their labs and to watch to see if they have any sort of symptoms, but there is a chance of going into remission on the medication. So you don't have to go to a more permanent treatment option like surgery or radioactive iodine right away. And some patients prefer to remain on medications. They never want to go and do kind of the more permanent treatment options. In destructive thyroiditis, so basically in destructive thyroiditis, it's not a problem with overproduction. Really what happens is it releases all the preformed hormone, so you get this hyperthyroid phase, and then patients can become hypothyroid and usually followed by euthyroidism, so their labs improve over time. So in destructive thyroiditis, you don't actually have to treat with like methimazole or PTU because it won't really tackle the actual underlying problem. So really it's just a tincture of time. Over time, things will improve on their own. If they are having pain in subacute thyroiditis, you can use NSAIDs and steroids initially to help with the pain management. And then when they're in that hyperthyroid phase, you can use beta blockers to control their symptoms. So I just wanted to include this chart on methimazole dosing. This can be found in UpToDate, and I think it's helpful in providing kind of where do you want to start in terms of how much methimazole to give. So it really is looking at those free T4 levels. If they're 1 to 1.5 times the upper limit of normal, or are they greater than 2 times the upper limit of normal, and what it could be a good starting dose of the methimazole. So the only time, so we usually choose methimazole as our starting medication because it has a lower side effect profile. Mainly, it has less hepatotoxicity compared to PTU. However, the only time that we might want to choose PTU first is during pregnancy. So in pregnancy, we treat with PTU in the first trimester and then typically switch over to methimazole in the second and third trimester. So moving on to subclinical hyperthyroidism. In subclinical hyperthyroidism, you see a low TSH, but a normal T4 and a normal T3. And we find this very commonly when we're checking labs for, some other reason. We find patterns of subclinical hyperthyroidism. So the question is what to do in subclinical hyperthyroidism. Do you need to treat it or not? It doesn't always need to be treated. So in young people and premenopausal women, as long as they're asymptomatic, you may just monitor them and not treat them. I think this next slide is actually a good chart to refer to. So this is in the ATA, or the American Thyroid Association guidelines, and this is when to consider treating subclinical hyperthyroidism. So in patients who are greater than 65 years of age, if their TSH is suppressed below 0.1, you want to consider treating them. You want to treat them. If their TSH is slightly higher than that, so 0.1 to 0.4, and they're elderly, you can consider treating them or you can consider watching them. If they have comorbidities, so the things that you want to look for are heart disease, osteoporosis, are they postmenopausal, and they're not on any sort of estrogens or bisphosphonates, or are they symptomatic? Then again, you can look at what their TSH is doing and either observe them versus consider treating them. And then even in younger patients, you can consider treating them when their TSH is suppressed. And then you can just observe them if their TSH is anywhere from 0.1 to 0.4. So this is a good chart to refer to if you're kind of confused of what you should do in a patient who has a low TSH but a normal T4 and T3. All right, so just quickly touching base on thyroid emergencies. So this is to help you distinguish, what is just thyrotoxicosis from thyroid storm. So thyroid storm becomes a medical emergency where you would want to tell your patient to go into the hospital. And it's not really based on your thyroid level, so it's actually based more on symptoms. So these are the things that kind of distinguish the two. So if they are confused, they have any sort of mental status changes, then you definitely want to send them into the hospital. If they're tachycardic, so if their heart rate is greater than 130, they're having any arrhythmias or signs of heart failure, that's pointing towards thyroid storm. They have any sort of GI distress. So really you're looking for kind of end organ damage. And that's an indication that they are pretty sick from the thyroid and they should go into the hospital. This is a scoring system that, again, this chart is on up to date. It's called the Wertowski scoring system. And it's basically a clinical guide to see if a patient may be in thyroid storm or not. A score of 45 or more on this is suggestive of thyroid storm. Again, this can never diagnose thyroid storm, but it's just a good clinical guide to see if your patient, if you need to be more worried about thyroid storm. So how do you treat thyroid storm? And this is, again, more inpatient, not outpatient, but patients, when they get admitted to the hospital, will be put on either PT or methimazole. They may get steroids and beta blockers, and as well as iodine solution. And this is to bring down their levels of the thyroid levels pretty quickly. And then myxedema coma is something else you want to think about in your patients. Again, this is something that would be treated in an inpatient setting, but as an outpatient physician, if you need to kind of think about whether it's a true emergency or not. If a patient has severe hypothyroidism and you're starting to see mental status changes, bradycardia, hypothermia, low blood pressure, changes in their labs like hyponatremia or hypoglycemia, those things you want to start thinking about myxedema coma, and they would need inpatient admission for basically fluids, IV levothyroxine, and potentially stress dose steroids as well. So that's it. Any questions?
Thank you so much, Dr. Kumar. That was really great and so detailed that we appreciate it. Yeah, we'll open it up for any questions. I believe we have 2 participants on, so we can kind of keep it catered to you two, which is really awesome as well. So feel free to unmute or chat in.
Thank you for the presentation, Dr. Kumar.
Absolutely.
Sorry. Yeah. Thank you for the presentation. It was really helpful.
Good.
I mean, one of my question is that when we see patients on amiodarone, okay, and many of the time that messes up their TSH.
Mm-hmm.
I mean, I had a situation, I was doing a pre-op on a patient and the patient was asymptomatic. And I checked the TSH because the patient is on amiodarone.
Yeah.
Okay, and he was hyperthyroid, but he was not symptomatic.
Yeah.
It was for eye surgery. And I read that it can, any surgical intervention during elevated TSH, it can precipitate thyroid storm.
Correct.
Okay. My question is, what can I do? I mean, I referred him to endocrinology because I was not sure, but what we can do at the primary care level?
Yeah, that's a great question. Amiodarone can be a little tricky because there's different reasons why you can become hypothyroid. So sometimes it's because of a destructive kind of thyroiditis picture, and sometimes it's because they have an underlying issue, like they have Graves' disease or a nodule that may not have been discovered, and it's basically the iodine load from the amiodarone that's causing the hyperthyroidism. So in those cases, I think right away what you can do is just symptomatically control them with potentially a beta blocker if they are having symptoms or tachycardia. If they're really not symptomatic, then I think it's okay and reasonable just to wait and see until they see endocrine, because sometimes the treatment is with things like methimazole, sometimes it's not. So it kind of depends on the cause, and it can be a little bit tricky in those settings. So only if the patient is symptomatic, I would say you should start like a beta blocker to try to help control their symptoms. And they shouldn't go for any surgery or any sort of procedure until it's further worked up and controlled.
And I missed your initial part when you were talking about hypothyroidism. I don't know whether you already talked about armor thyroid.
Yeah, I didn't mention armor, but you know, we don't love using armor thyroid for hypothyroidism. Basically, it's pig thyroid. It has both T3 and T4 in it. A lot of patients come in on armor thyroid, or they say they feel better on armor thyroid. The problem with armor is that it's not as regulated, so the ratio of T3 and T4 can vary from different pills, pill to pill, and patients can be more at risk for becoming hyperthyroid because of the T3 that's in it, especially in elderly patients who have a history of any cardiac problems or AFib or osteoporosis. We have to be careful when they're on armor thyroid. So generally the practice is, at least for us, to switch them over to levothyroxine if possible, and to get them off of the armor thyroid. So we generally do not recommend using armor.
And how do you switch it? I mean, is there any formula to switch to levothyroxine, or you start with the low dose and then go up high?
Yeah, if you actually just Google it, I don't know at the top of my head, there's a good chart that I always refer to. If you just Google levothyroxine to armor conversion, it's a chart that comes up, and it basically tells you the dose of the armor and what's that equivalent to in levothyroxine. And I generally start there, or maybe a little bit less with levothyroxine, depending on kind of how their labs are looking on the armor. So it's just a chart you can find online.
Okay. And if the patient insists on being on armor thyroid, I mean, I know it's very difficult to adjust.
Yeah. Yeah, if the patient insists, I think in our practice it's a little different because they kind of screen them out and they say that we're not going to prescribe it. So we have less, you know, we see less of those patients. They already know that if they're coming to see us, that it's not going to be prescribed. If they insist and their labs are looking okay, I have left patients on it as long as their, you know, TSH looks okay, their free T4 looks okay. I've left patients on it. The only time that you have to absolutely take them off is during pregnancy. So in young patients during pregnancy, you want to take them off armor because it's important. Basically, it's hard to regulate the levels for the mom while she's pregnant. And that's really important for the baby to have, you know, good, for the mom to have normal thyroid levels during pregnancy. So in those cases, I absolutely don't prescribe it. In other cases, if they really, really want to be on it and they're otherwise stable, then it's okay to continue it.
Okay. I mean, I had a situation where I had a mentally challenged patient who was managed by his institution and was transferred to me.
Yeah.
Okay. And whoever the guardian was, their recommendation was that the previous doctor said that he should never be on levothyroxine. I mean, thankfully, so far, it is still in the normal range. So I continued the armor thyroid, but I always worry that if it's high or low, how will I change it? Because I tried to change it and it was very difficult.
Yeah. And those patients are challenging. There are some patients who claim that this is the only medication that works for them, and they want to be on it. So, you know, in those cases, I just keep watching the labs closely, and if it's stable, then I keep them on it.
Yeah. And my next question is that when you are managing hypothyroidism and it is still like everywhere. I mean, I have one patient, she's sometimes on 15, 60, something like that.
Yep.
And initially, my strong suspicion was she was non-compliant. But now with the doctor's help, I know that now she is taking and it is improving.
Yep.
But even after trying to regulate it, and if it's not coming within the normal range, what could be the potential reasons for uncontrolled hypothyroidism where the patient is compliant?
Yep. Sometimes that's a good question. Sometimes it's an absorption problem. So checking for like celiac antibodies could be helpful to seeing, even if a patient's not kind of complaining of any sort of GI symptoms. That's something that we check for. If they're taking it, with other medications, so definitely making sure they're not taking it with like a PPI, like pantoprazole. Are they taking it with any sort of multivitamins, calcium, iron supplements? Those things need to be separated by at least 4 hours. So even if they're taking it every day, just making sure they're taking it properly and not taking it with some of those medications. That's usually one thing that we find. If it's really going up and down and you don't have a reason, sometimes switching over to a formulation called Tirosint can help. So Tirosint is less affected by other medications or by any GI, maybe an underlying GI issue that we just don't know about. And so sometimes patients actually stabilize on Tirosint, which is just another kind of formulation. The dose is the same.
How do you spell it? Tirosint?
Tirosint.
Okay, tyrosine. Okay.
Yeah, so that's one option, but I think just making sure there's no underlying GI or absorption issues is usually the first thing that we think about. If it is the compliance issues, like sometimes in clinic we do an absorption test. So we basically bring them into clinic, we give them a full dose and check their labs kind of before and after and see if they are taking it or are they not absorbing it. But those are usually the issues that we think about.
Okay, thank you.
Mm-hmm.
Thank you for the questions, Dr. Pollywall. You always have great commentary. We appreciate it. Thank you, Dr. Kumar, for addressing those questions.
Absolutely.
Any other comments, questions, or thoughts from anyone? Doesn't necessarily have to be a question. Alrighty, well, we will finish the session, but I wanted to
Dr. Kumar,
Oh,
if you
go
don't
ahead.
mind, I mean, I have a patient who is coming. I'm checking for adrenal insufficiency.
Yes.
And I don't check it often. So I ruled out everything. Now I'm checking for testosterone and the cortisol and ACTH.
Yes. Uh-huh.
Okay. Now correct me if I'm saying wrong. I mean, first, specifically for adrenal insufficiency, they get their cortisol and ACTH drawn at 8 o'clock.
Correct.
And you give them 250 microgram of dexamethasone.
No, so if you're doing for adrenal
Screening.
insufficiency, then you just need a baseline 8 a.m. cortisol and ACTH. You don't need to give them anything. The dexamethasone is if you're looking for the opposite problem, if you're looking ruling out Cushing's disease.
Okay.
So that will kind of suppress their cortisol. Now, if their cortisol comes back in an indeterminate range, so if it's usually in the morning, if it's usually like 10 or 11 or greater, that's pretty, a morning cortisol, that's pretty good. And I would say they don't have adrenal insufficiency and you don't have to do any further workup. If it's less than 10, then you need to go on and do that stimulation test. So that's when you give them 250 micrograms of cosentropin. Yeah, so you check the 8 a.m. cortisol, you give them the cosentropin, and then you check a cortisol 30 minutes later and 60 minutes later, and you want to make sure that number goes up to 18.
Okay.
But you can start with, if you're just screening them, I would just start with an 8 a.m. labs, 8 a.m. cortisol and ACTH.
Okay. Thank you so much.
Yeah, no problem.
Thank you, Dr. Pollywall. Any other thoughts or comments from the group? So the only thing Elizabeth and I wanted to kind of run by you all, and I wish more folks were on here as well. And I know Dr. Giordano was on, but I think she had to run to a patient. But we know we've been having these endo echoes from 12 to 1 p.m. So I know, Dr. Kumar, you were saying the clinic ends right around noon. Is that correct?
Yeah, we end around noon. I know everyone's a little bit different time, but yeah, usually around noon.
Okay, so with that, we wanted to kind of gauge and see what you all thought about maybe having these sessions go from 12:15 to 1:15 instead. We don't have to, it's just a thought we wanted to put out there for everyone. So it might be easier to have, you know, folks get a moment to like maybe get food or water before the session after clinic, that little like leeway time. So just, you're more than welcome to unmute, mention your comments, thoughts about that. But yeah.
Yeah, I think with from our perspective, I think that would work well. 12:15 start.
Okay. And it looks like Dr. Pollywell, you said either is fine. Okay, that's very helpful. So with that, Elizabeth and I will kind of determine maybe a new time frame of the 12:15 and 1:15. We are starting curriculum development, so it might be a perfect time to make that change if we do that change. So we'll be in touch with you all about that time frame moving forward if we decide to change anything. So just keep an eye out. But any final comments about the session? Alrighty, well, thank you so much, Dr. Kumar, as always. You do a wonderful job presenting and answering questions, so we really appreciate you.
Thank you so much.
Yeah, the only announcement I have is our next session will be on May 25th, and Dr. Hugh Quinn will be presenting on coverage for outpatient diabetes care. So we hope to see you all again next time. Thanks, guys.
Thank you. Thank you.
Bye.